Hello and welcome to a tutorial on acid-base balance. So to better understand this, it requires you to have basic or prerequisite knowledge on the normal physiology of acid-base balance, including renal function, right? So we will talk about four entities, two of them being acidotic in nature. So we will talk about metabolic acidosis mostly, then we'll talk about respiratory acidosis. Then we will talk of alkalosis. So in alkalosis, I'm going to mention metabolic alkalosis. And then you also talk about respiratory alkalosis, right? So, right. So we want to understand certain things that govern acidosis and alkalosis, and basically we are worried about the fact that we have H plus ions plus bicarbonates, which gives us CO3, bicarbonate acid. Then we also then talk about carbon dioxide plus plus water. But the eco signs that are there in between, they're not unidirectional, they're bi, meaning we can say carbon dioxide and water, then H plus plus bicarbonate, which can give us bicarbonate carbonic acid. So what then happens is, imagine a scenario where we have excess bicarbonate being formed. If we have excess bicarbonate being formed ions, they will tip the reaction towards the left where there's carbon dioxide and water. Then you reduce H plus ions. A reduction in H plus ions will lead to alkalosis. Imagine a scenario where there's increase in H plus. The increase in H plus will shift the reaction also to the left and decrease your bicarbonate and leading to an acidosis type of a picture. So those are kind of like basics that you need to carry with you for things to make sense in acid-base balance. But remember, what really regulates the balance of bicarbonate ions is the kidney. Then what regulates carbon dioxide is the respiratory system, the lungs in particular, where we then think about hyperventilation versus hypoventilation. So the two main things that are key here is the bicarbonate ions as well as your carbon dioxide, right? Then so all the other things that we then think about, they are basics like what happens when we have excess carbon dioxide in the body, what happens when we have excess bicarbonate, what happens if but the normal pH, remember, it ranges between the range between 7.35 to 7.45, 7.40 being the average. Then life exists between pH around 7 to pH around 7.8. Outside those values, it becomes quite dangerous to actually be walking outside, right? So the main players in this case is your lungs, where we have the respiratory component. Then the kidneys also play a role in excreting your bicarbonate, right? So there is no other way of excreting these acids except for those two systems. The non-volatile acids being excreted by the kidneys, then the volatile ones by your respiratory system. So how does the kidney do this? You remember the reabsorption mechanisms that exist in the proximal convoluted tube, where it allows carbon dioxide and water to seep through into the PCT cells, then this whole equation kicks into play. Then there's reabsorption of the ions. I won't talk about the physiology, right? Then there is also excretion of some acids from the renal system to allow for um, sort of like a homeostasis for these things. And then we also have the issue of buffers. Remember, some of the acids will actually act as buffers. So just remember that we have the buffer system, which you can revise in physiology. And a buffer is simply a weak acid that is going to form a conjugate with a base, right? And these, they actually guard against changes in pH as well. So buffers are there also in acid-base regulation, and they're going to help us with normal acid-base balance. Right? So they are part of your control systems, and we have a lot of buffers in the body that help with this, right? So I will start off with things like metabolic acidosis. So metabolic acidosis is one of the main, or if not the main one, that is of importance as compared to respiratory acidosis. But before we go there, there's an issue where we talk about compensation. Right. And what is compensation? When we have an acid-base disorder, when the body tries to respond and form a compensatory mechanism, that's what we call compensation. And when you look at the pH, and the pH is still not yet corrected, but there is some changes in values. I'll show you how you see the changes in values. It will still be a partial compensation, but there is also full compensation where we see that we have the pH now falling within normal ranges. But also we have what we call mixed acid-base disorders, where one entity can exist with another entity, meaning you won't only maybe have a respiratory acidosis, maybe there will be a metabolic acidosis also in play, right? And there's also something that I want you guys to understand, which we call the anion gap. So the anion gap is simply sodium. It's simply going to be sodium minus, open bracket, chloride ions plus bicarbonate ions, close bracket. So this is the anion gap, and normally we allow for a leeway 12 plus or minus 4. I think I can put it this way. Plus or minus 4 there, right? So we allow for this kind of range because we have certain things that cannot be accounted for. Some of these are going to be acids, some are going to be proteins in this kind of a formula. That's why we have this gap. So when we do then metabolic acidosis, you're going to find that we have certain conditions where you get an acidosis with a normal anion gap, or you can get an acidosis with an abnormal anion gap. So all those are going to be different scenarios in which you can have, right? So how do we differentiate between the four? Someone with a respiratory acidosis, what do you think? Carbon dioxide is more likely going to be high. So we're thinking about the lungs, we're thinking about carbon dioxide, eh? So there's an increased partial pressure of carbon dioxide for someone with respiratory acidosis. What about someone with respiratory alkalosis? It's just a decreased partial pressure of carbon dioxide. Remember, the main players are carbon dioxide and bicarbonate. So when it's metabolic acidosis, what happens to the bicarbonate? It goes down. And what does it do when it goes down? It's going to shift the reaction way towards that side and increasing H plus ions, and you get the acidosis, right? Then the opposite, which is now metabolic alkalosis, you now have an increased partial pressure of not partial pressure, but an increased concentration of hydrogen carbonate. When it's high, it's going to pull the reaction towards the left. Maybe whichever way you want to put it, you put the reaction towards carbon dioxide and water, and that decreases H plus ions. Then you end up with an alkalosis, because remember, pH is just the negative log 10 of that H plus concentration, something like that. If you remember your chemistry, I haven't done that in a while, but just need to remember that, right? then you can get cases where pH values remain between the normal range, 7.35 to 7.45. So this can be normal, but it can also be abnormal, right? So usually you can also have mixed disorders, right? Maybe you have both an alkalosis and an acidosis in the same time. So you end up with a pH that is quite normal. Then you can also think about some chronic conditions like chronic respiratory acidosis, chronic respiratory alkalosis. All those things can lead to a pH that is quite normal, but then leading to some problems, right? So what am I going to start with? I'm going to start with what we call metabolic acidosis. Right. So what's happening in metabolic acidosis? Remember I said this is a disorder where the hydrogen carbonate ions are going to be. If you remember what I was saying, pause a moment and think about it. What's happening is that hydrogen carbonate ions, they're more likely going to fall. If they fall, they put the reaction towards that side, leading to an increase in H plus ions. Right. So how do we cause metabolic acidosis? We can think about anything that's going to cause the fall in the bicarbonates. Maybe there's renal dysfunction. I'm unable to properly reabsorb bicarbonate. Maybe there is accumulation of acids in the body secondary to some process. For example, I can have diabetic ketoacidosis. I can have any form of fat metabolism. I can think about anaerobic respiration, which leads to buildup of lactic acid, or even the kidneys can fail themselves to excrete some of the acids. Right. So there is a mnemonic that we normally use for us to know. So it's MAD has MAD pause. These are the causes of metabolic acidosis. So this is going to be methanol. Oh no, didn't want that. Uremia. Right, these the diabetic ketoacidosis that I was mentioning. PL, I'm forgetting, I'll skip it. So we also have lactic acidosis as the L. Lactic acidosis. Then the S there is the salicylates. I'm sure you've done pharmacology. Salicylates, then the I there is tablets. So we talk about isoniazid, part of TB medication, first line treatment, as well as iron tablets, but mostly isoniazid. Then the P there is, I think, propanol glycol. Then there is an E there, which is ethylene glycol, which I won't talk about. Right. So these are some of the causes of metabolic acidosis, but these are causes of metabolic acidosis with a high anion gap. So anything that is going to increase acid, as you can see. So remember the anion gap. The anion gap, the formula was sodium minus, open bracket, chloride plus bicarbonate, close bracket. Right. So if these conditions are going to increase acid, remember what I said about metabolic acidosis. In metabolic acidosis, the bicarbonate will go down. So if this bicarbonate goes down, notice what's going to happen to the anion gap. It's going to be quite high. Imagine 10 minus 5 versus 10 minus 2. The anion gap goes high, right? That's why we have a high anion gap. But imagine situations where even though the bicarbonate is going down, the chloride starts to go up. That is going to cause a metabolic acidosis with a normal anion gap. The mnemonic for that one is hardest. Right. So these are things that then cause metabolic acidosis, but then there's a normal anion gap. Most importantly, there is a drug that we call acetazolamide. Right, so some of those things you may need to understand the mechanism of actions. Is there is spironolactone. So spironolactone, then the other H, the A, can talk about Addison's disease. The D, there is diarrhea. Don't mind my spelling. Then the other S there, you can start repeating to saline. Then the H and the R. R is renal tubular acidosis, mostly type 2, but any other form of renal tubular acidosis can lead to a metabolic acidosis with a normal anion gap. Right. Then H is hyperalimentation, where there is excess or more movements that are happening within your alimentary canal, right? So this is metabolic acidosis. So how do we compensate for metabolic acidosis? So there is a way that I was taught when I was still young. If the problem is with the metabolic system, the kidneys, maybe the kidneys are not working, how do we compensate? We compensate with the respiratory. There's a problem with the respiratory. What do we do? Compensate with the kidneys, right? So how do we get rid of metabolic acidosis? I will hyperventilate. If I hyperventilate, I'm going to lose excess carbon dioxide. The hyperventilation is what we call Kussmaul breathing, if you remember your respiratory physiology. Right. Then, of course, yes, the kidney can still help with some form of excretion of potassium. Not potassium, but H plus. But H plus, when you excrete H plus, you're going to exchange it with potassium. Right. Always remember that. Then there's a way to look at compensation in metabolic acidosis. We call it the Winters formula. This is a very nice formula that you should adopt because it helps you with understanding whether there is correct compensation or not. So there is partial pressure of carbon dioxide, which put it like that is equals to, right? So that's going to be 1.5 times, where is my times here? I can use the asterisks, I think. 1.5 times the value of hydrogen carbonate that you are given in your question. It's supposed to be there, though it's not supposed to be there. The value of hydrogen carbonate given in your question. Remember bond mass, what comes first? Plus 8. Close bracket, where is the bracket? Close bracket. Then it should be plus or minus 2. Plus or minus 2. Right. So say we're given a bicarbonate concentration of 17, right? The normal is around 24. Let's say we're given an answer. So we're going to say 1.5 times 17. The answer that I get there, I'll add 8. After I add 8, the whole value that I have becomes a range where there's the lower limit, the -2, and the upper limit, the +2. That becomes the range that I have, right? So there are cases where so this is the calculated, right? So when the calculated partial pressure of carbon dioxide. So when the calculated partial pressure of carbon dioxide is going to be less than the measured partial pressure of carbon dioxide, right? This means that we are in metabolic acidosis that can be associated with the respiratory acidosis. They're going to be 2. right? But when the measured is less than the calculated, it's a metabolic acidosis associated now with a respiratory alkalosis. That's why we'll now have the measured partial pressure of carbon dioxide coming to be down. Okay. It's quite useful for us to know issues to do with the anion gap and the Winter's formula for us to be able to understand how things are really happening, right? So the normal anion gap metabolic acidosis, the main cause there is the diarrhea, right? And usually we're thinking about how there's bicarbonate in your small intestine fluid, right? Okay. Then what are some of the effects that you have for metabolic acidosis? You're simply thinking about how you have increased H plus. What does it do? It stimulates the respiratory center. You hyperventilate. You get the Kussmaul breathing, and you can also end up with a hyperkalemia, because what's going to happen is the H plus is going to go into the cell and the potassium will come out, and we get hyperkalemia. Right, this will cause cardiovascular problems, as well as some neuromuscular problems, which can even lead to death. So how do you treat? You have to identify the underlying cause. If you identify the underlying cause, you can correct it, right? Then on the other end of the spectrum, there is respiratory acidosis, right? So remember I said when it's respiratory, I'm thinking about the partial pressures. So when it's respiratory acidosis, I'm thinking about partial pressure of carbon dioxide that is going to be quite high. So I'm going to have what I call hypercapnia, elevated blood partial pressure of carbon dioxide. Right. What are some of the things that cause this? I have elevated partial pressure of carbon dioxide. That means that I'm not adequately ventilating, so I can have a foreign body inhalation that can dislodge in the lung and cause a blockage. I can have chronic obstructive airway conditions like bronchitis, emphysema, the things that you've done in your histopathology when you're doing respiratory system, right? So those things all can cause that form of in a sense of airway obstruction, or the respiratory centers are quite deep, actually quite compressed. That means I'm not having them function well. Maybe there's head injury, there's a tumor inside there, there's an abscess, right? Or even physical injury, the chest apparatus, the intercostal muscles are not adequately doing it, the diaphragm is not adequately working. So all these things, even severe pulmonary disease, think about a baby who's having severe pneumonia, and you're trying to have them breathe, they're not going to be breathing quite well, right? So how do we compensate for a respiratory acidosis? Remember I said the most important the thing that's more important when there's a respiratory problem, the kidney will be. And what is the kidney going to do if I have excess acid? The kidney is going to try to retain some bicarbonate. The kidney is also going to try by losing much of the acid, right? So compensation for respiratory acidosis is quite similar or quite simple, that we just have to have the kidneys functioning. Right? So there are graphs that are used to assess compensation for respiratory acidosis. So Winter's formula, I used it for metabolic acidosis. I'm not going to use it for this because it doesn't really apply. But you need to be able to find a way to as this is the mnemonic that we use for causes of respiratory acidosis. So as a cow, airway obstruction, sedative use. Sedatives can also actually compress the respiratory center. Then, so that's S. Then it's supposed to be breaks in between as a cow, but acute lung disease, chronic lung disease, opioids, or even weakening of respiratory muscles. All these things um, can cause um, respiratory acidosis. So all this can be causes of respiratory acidosis. Right. What are the signs and symptoms? These are going to be breathless, they can be lethargic, they can actually convulse, have tremors, and they can actually also die. Right. Then on the other hand, we have respiratory alkalosis. This is now where we have hyperventilation. So I'm losing excess carbon dioxide. So I have hypocapnia, less partial pressure of carbon dioxide. So what are some of the things that can cause um, respiratory alkalosis? So I'm thinking about anything that can cause hyperventilation. So it can be a pulmonary disorder, problems within the lungs. Maybe there's an embolism, asthma. You're trying to breathe. Can be problems with the respiratory exchange itself. But when you're compensating for that one, right, so you have excess carbon dioxide, but you have less carbon dioxide rather, but the respiratory system is not functioning well. Right. So what does the kidney do? The kidney will excrete bicarbonate. Right? The kidney will promote excretion of bicarbonate. And when you excrete the bicarbonate, this is now some form of trying to compensate. Right? So there are limits of compensation for acute versus chronic. When it's an acute respiratory alkalosis, the limits of compensation will be around 18 millimoles of that bicarbonate. Then when it's chronic, it's about 12 millimoles. That's some of the compensatory limits, but you can get a bicarbonate that is less than the 12. That is the lower limit for chronic compensation. Right. This is where we then have a mixed respiratory alkalosis combined with some form of metabolic acidosis. Right. Then they can be over 18. So this one you have a respiratory alkalosis mixed with something else that can be a metabolic alkalosis or even a or just maybe there is no compensation that is happening whatsoever. Right. Okay. Then on the other hand, we also then have metabolic alkalosis. Metabolic alkalosis, now think about alkalosis bicarbonate. So there's high bicarb. So maybe you have excess kidney retention of the bicarb, or you are having excess ingestion of that. So what are the causes of metabolic alkalosis? So this can be caused by you're losing H plus ions from the body, either due to vomiting or even diuretics in your medications, whatever. All these things can cause loss for metabolic alkalosis, right? Then these people can also get hypokalemia, right? So you need to understand that your four parameters are quite different. How they present is different. This is just more of a summary, but how they present is different. How they're compensated is different, and how they're actually going to have effect on the body. Right. So we also talk about something called a delta ratio. So delta ratio now is not really an ion gap, but when you have an elevated anion gap, we then do what we call the delta gap. Right. So the delta gap is now the patient's anion gap, the one that is elevated, minus the normal anion gap is around 12. Right. So when you want to check if there's a mixed disorder, acid-base disorder, right? When you have a high anion gap, what do you simply do? Remember those causes. So maybe there's a mixed disorder. You add that delta gap, which I said it's the patient's anion gap minus the normal 12. You add that delta gap to the patient's bicarbonate. Right. If the value lies between 22 and 26, it's a normal disorder, a simple disorder where there is no mixture. If the value is going to be less than 22 or greater than 26, it is going to signify a mixed blood gas disorder. Right. So it becomes really simple if you understand the physiology of these things. Right? You don't need to cram how. I understand when I was doing physiology at the time, I used these graphs to try cram that if the graph is going up at this point, the graph is going down at this point. This is mixed gas. This is what, but it doesn't have to work like that. So we call it an acid-base nomogram. You can look it up if you want, but I don't think it's quite important for you to claim to those extents, right?